Under bronchodilators, we have the alpha and beta adrenergic agonists. So it's mainly alpha 1 and beta adrenergic agonists. So these medications are often used during acute phase of asthma attack. But we'll go over it a little bit more and we'll specify which specific one is used during acute phase. And we'll talk about the difference between short acting versus control medication. The mechanism of action for alpha and beta adrenergic agonists would be stimulating the alpha, beta 1, and sometimes, depending on what medication we're talking about, beta 2 receptors in the lungs. And so there's an increase in CAMP or cyclic adenosine monophosphate molecule, which act as a messenger in the body. And within the intracellular messenger, there's a decrease in intracellular calcium that causes smooth muscle relaxation in the bronchioles. Now, when it comes to the non-selective alpha-beta stimulation, there's alpha and beta stimulation, so therefore, it's a combination of both. Remember what I told you with the beta, so there's cardiovascular involvement and respiratory involvement, so it causes vascular constriction and bronchodilation. Therapeutic effects, what are usually the effects that we want on the selective alpha and beta adrenergic agonists? We want bronchodilation, right? So for beta 2, so again, beta 2, we have two lungs. So it causes relaxation of the bronchial smooth muscles. Therefore, from that relaxation, it increases airflow in and out of the lungs. Now, on the non-selective ones, it causes vasoconstriction and bronchodilation. So in addition to what we want, the bronchodilation, there is a constriction on the cardiovascular side of the system. So that's for alpha, beta 1, and beta 2. So those are non-selective indications. So what are the reasons why we would give somebody alpha and beta adrenergic agonists? One, well, we want it for its bronchoconstriction properties and vasodilation. So again, for the selective aspect, selective when it comes to the respiratory system, then we want to use it for asthma, especially an acute asthma attack, reactive airway disease, and allergic response. So this right here is an image of a comparison of a normal airway, and then we have the asthmatic airway. So as you can see, during an asthma attack, there's many things that can happen, right? So during an asthma attack, there's some thickening, there's some mucus production, and then also there's spasming of smooth muscles. So they're contracting, so they're making the airway smaller. So the alpha and beta adrenergic agonists will act in these smooth muscles, right? And it causes the relaxation, which helps with the airflow in and out of the lungs. So that's where this works. Now, on the other hand, we have the non-selective, which again causes vasoconstriction. So because of its effect, it's often used for hypotension or shock. As I mentioned in the beginning, there are medications that are considered control and there are medications that are considered rescue. So the control ones would be the long-acting alpha and beta adrenergic agonists. That's basically more of a maintenance, something that the patient will take daily to maintain their condition. The rescue, on the other hand, would be a short-acting medication. So that will be often used as a PRN or as needed, and most likely is during an acute asthma attack. So again, it is very important to differentiate which one is long-acting and which one is short-acting. We're going to discuss the importance of that in the nursing actions or interventions and patient education. Now, when it comes to precautions, because of its effect on the cardiovascular system, some of the precautions include cardiac dysrhythmias and then possible increased risk of stroke and MI, especially for people who have pre-existing cardiovascular illnesses because of the property that this medication has, right? Especially the non-selective ones, it causes vasoconstriction. So we have to be very careful with that. When it comes to contraindications, so absolute contraindication for the most part would be uncontrolled cardiac dysrhythmia. Again, if we know that this medication may cause cardiac dysrhythmias or may worsen it, then if somebody already has something that we can't even control, it is better to avoid giving this medication. So again, a contraindication for this drug is uncontrolled cardiac dysrhythmias. From the precautions and contraindication, then it just makes sense because common side effects will include tachycardia and palpitations. Sometimes it can also cause insomnia and restlessness. Going back to tachycardia and palpitation, it is very important to let the patients know that for people who've never been on this medication, so let's say this is a new medication for them, it is quite common for patients to experience tachycardia and palpitation at the beginning, and usually it goes away by itself. And for the most part, it's nothing to worry about. We still need to monitor, but we don't have to panic right away, as these side effects can go away over time, and especially as long as the patient is tolerating it well. This can also cause some anxiety and tremors and nervousness, especially because this is kind of stimulates your adrenaline. It can cause some anxiety and restlessness when they are on this medication. So that would be something that you may wanna tell your patient before giving this medication. When it comes to nursing actions, again, we want to monitor for therapeutic effects as well as side effects. So are we achieving the effects that we want? Is the patient breathing better, or is the patient experiencing any side effect? In addition, we also want to monitor for heart rate and rhythm. Why? Well, because we know that a common side effect would be tachycardia and palpitation. Then we want to know, how's our patient doing? Are they experiencing any side effect? If a patient is complaining of some symptoms, again, we can let them know that that's often expected and it should go away. But that being said, we also need to take it seriously, especially if they say that they can't tolerate it, because then the doctor may be able to make some adjustment, or sometimes they just need to switch medications. So it is very important to assess their pulse as well and make sure they don't have additional symptoms accompanying the palpitations. So once they start having chest pain, then obviously we have to take it seriously and assess them fully and making sure they're not having a heart attack, right? Because then we also know that can put them at a higher risk of developing a stroke or MI. Patient education aspect, again, we need to educate our patients regarding the dosing. What's the right dose? How often are they supposed to take the medication? And a very important piece is we need to make sure that they know which medication is their control medication and which one is their rescue. So it's also very important to tell them, read the label, because sometimes a lot of the patients, they will tell me the red one is for control and the blue one is for rescue. Well, it may be true for certain manufacturers, but actually there are manufacturers who actually switch that. Sometimes it can be a different color. So it is not reliable to use the color. Basically educate them, know the name at least, and know which one. And if they forget, definitely label it, have them bring it to their doctor's office so they can label one as a control, one as a rescue, so they know which one to grab, especially if they're having an acute asthmatic attack. Again, very important to know which one is a control and which one is a rescue. So these are examples of drugs in this class. So we have the selective beta 2 agonists. So those are more for your respiratory system, right? We have Proventil or albuterol. This is short acting. This is the most common thing that you see patients on who have asthma or other pulmonary illnesses that would require them to have a rescue medication. So oftentimes this is used as needed. So this is the Proventil or albuterol, which is short acting. Zopinex or levalbuterol is also another short acting medication. But that being said, it's not as commonly used as albuterol, but we see them depending on what's available in the market and which one is covered by the insurance. But the most common one would be your albuterol. Now, you also have salmeterol or Ceravent. This is a long-acting medication. So we need to make sure that we let the patient know that in case they're having an asthmatic attack, that this is not the medication to grab that will help them breathe almost immediately. So the medication that they need during emergent situation or as needed is a short-acting albuterol. And then the Ceravent or salmeterol is going to be the one that they often will take daily as a maintenance medication for their respiratory illness. Then the non-selective alpha and beta agonists, we have adrenaline or epinephrine. So this medication will cause vasoconstriction and bronchodilation. So again, this is non-selective because we have the alpha and beta agonists that affects both the lungs and the cardiovascular system. Now we have selective beta 1, beta 2 agonists, Alupen or metaproterenol, which we don't really see much in the both outpatient and inpatient setting, but it's just good to have an idea of what it is. Now, we also have combination medication. So this specific one, Advair or salmeterol and fluticasone. This medication is a combination of alpha and beta adrenergic agonists combined with steroid or corticosteroid. And this is considered as a long-acting and maintenance medication. And again, it's important to let your patient know if they're on this that this is not their rescue medication.